Welcome to Healthy Kidneys After 60. I am your host, Jane Pauley. We often think that the biggest dangers in our later years are the long-term diseases we cannot control, but sometimes life changes forever in just a few short minutes in the quiet of our own homes. Today we are talking about those critical moments, specifically the 7 minutes you wait for an ambulance. I am deeply honored to be joined by a man who spent his life translating the complexities of the human body into hope for millions, CNN's chief medical correspondent, Dr. Sanjay Gupta. Sanjay, thank you for being here with us.
It is a privilege to be here, Jane. You know, in the emergency room, we see people at their most vulnerable, and so often the family members standing by feel completely helpless. But the truth is, what happens in your living room or kitchen before I ever see the patient can be the difference between a recovery and a tragedy. I am so glad we are having this conversation because it is time we turn that feeling of helplessness into a sense of empowerment for every senior and every caregiver listening today.
You know, Sanjay, I was thinking about a story recently that really shook me. Imagine a quiet Tuesday afternoon, the sun is streaming through the kitchen window, and you are just reaching for a glass of water. Then, in an instant, the world tilts. You find yourself on the floor, unable to speak, unable to move, just waiting for the sound of a siren. It is only 7 minutes, the average time for an ambulance to arrive in a city, but those 7 minutes can feel like an entire lifetime. For many of our listeners who are in their 70s or 80s, there is this haunting, unspoken fear that one day they will fall and that will simply be the end of the story. I want to ask you, as someone who understands the clock of the human body so well, is it true that for the elderly, a single fall is a point of no return? Or is there something we are missing in those crucial 7 minutes of waiting?
Jane, that image you painted of the quiet kitchen suddenly turning into a life and death scene is exactly what haunts so many families. And I want to start by saying something very important. It does not have to be the end. The fear is real, but the helplessness is often based on a misunderstanding of what is actually happening to the body. When someone collapses, we naturally focus on the heart or the brain, but often the most immediate danger isn't the underlying medical event itself, it is the airway. In those 7 minutes you mentioned, many people don't lose their lives because the ambulance was too slow or because they were too old to survive the event. They lose their lives because their airway closed or they choked or the blood flow to their brain was further compromised simply by how their body was positioned on the floor. It is a biological reality that as we age, our bodies become much more sensitive to shifts in oxygen and circulation. A young person might tolerate a restricted airway for a minute longer, but for a senior, every second of clear breathing is a lifeline. This is why the guidelines from major health organizations like the American Heart Association and the Red Cross place such a massive emphasis on the recovery position. It is not just a first aid step, it is a clinical intervention that anyone can perform.
That is a powerful distinction, that it's not just about the event, but about how we manage the body during the wait. It makes me wonder about the golden window we always hear about. We are told to act fast, but in the panic of the moment, most people just want to scream for help or maybe try to shake their loved one awake. If a single movement or a single change in how someone is lying can change the entire outcome, it feels like we are carrying a heavy responsibility. Can you help us understand the science of that? Why does a simple shift in position actually keep someone alive when their body seems to be shutting down?
It comes down to basic physics and anatomy, Jane. When a person becomes unconscious or even just severely disoriented, the muscles in their throat relax. The tongue, which is a very strong muscle, can actually fall backward and block the airway entirely. If that person is lying flat on their back, they are fighting gravity just to get a breath of air. Furthermore, if they happen to vomit, which is a very common reaction to many medical emergencies, and they are on their back, they can easily inhale that fluid into their lungs, leading to aspiration or immediate choking. When we talk about the recovery position, turning someone onto their side with their head tilted back, we are essentially using gravity to our advantage. We are ensuring the tongue stays forward and any fluids can drain out of the mouth instead of down the throat. We are protecting the golden window of oxygen delivery to the brain. Throughout this episode, I want to walk everyone through exactly how to do this, but the first thing everyone needs to realize is that you are not just a bystander. By ensuring a clear airway through the right position, you are doing the work of a doctor until I can get there with my team. You are keeping the flame of life flickering when it's trying to go out.
It sounds like such a small thing, just a turn of the body, but the consequences of getting it wrong are terrifying. If my husband or my neighbor collapsed right now, my instinct might be to just stay by their side and pray, but you're saying I need to be their protector in a very physical way. What is the one question we should be asking ourselves the moment we see someone hit the floor?
The question is, are they breathing, and is that breath safe? If they are breathing but not responding to your voice, that is your signal to act. If you leave them on their back, you are leaving their life to chance. If you put them in the recovery position, you are giving them a fighting chance. It is the difference between a patient who arrives at the hospital ready to be treated and a patient who arrives with irreversible brain damage or a blocked lung. That is why this 7-minute fate is something we can actually control.
There is a silence that lives in many homes today, Sanjay, a quiet anxiety that follows our seniors from the bedroom to the kitchen. I hear it in the voices of my friends and my viewers, this deep-seated fear that their independence is just one slippery floor or one dizzy spell away from vanishing. They tell me they walk a little slower, they grip the handrails a little tighter, not just because their joints ache, but because they are terrified of being a burden or worse, being found too late. It feels like the home, which should be a sanctuary, slowly becomes a place of hidden dangers. I wonder if you can speak to that emotional weight, the way the fear of a fall can actually paralyze a person's spirit long before they ever lose their physical balance, and how we can start to reclaim that sense of safety in our own daily lives.
You have touched on the very heart of the matter, Jane, because the psychological impact of falling is often more debilitating than the bruise or the broken bone. I remember a very specific case that illustrates this perfectly. A lovely woman named Mary Collins, who is 74 years old and lives in Tampa, Florida. Mary was the pillar of her family, the one who cooked the Sunday roasts and kept everyone together. But she started experiencing what we call orthostatic hypotension. Basically, her blood pressure would drop when she stood up too quickly. One afternoon, while she was just trying to make a cup of tea, the world went dark. She collapsed right there on her linoleum floor. Her husband, who was in the other room, heard the thud and rushed in, but he was paralyzed by that exact fear you described. He didn't know if he should lift her up, if he should give her water, or if moving her would break something. He just knelt there, shouting her name, watching her face turn a pale, dusty gray, while her breathing became shallow and raspy. This is the reality for so many. They don't want to admit they feel dizzy because they don't want to lose their car keys or be told they need a caregiver, so they suffer in silence until a crisis happens.
It is heartbreaking to think of Mary's husband in that moment, wanting to help, but being terrified that his own hands might cause more harm. I think many people would instinctively try to pull someone up or prop their head up with a heavy pillow because we want to see them sitting up and talking again. It feels wrong to just leave them on the floor, almost like we are abandoning them in their moment of need. Why is that instinct to get them up so dangerous? And what is actually happening inside the body of someone like Mary when they are handled incorrectly during those first few minutes of a collapse?
That instinct to pull someone up is perhaps the most dangerous thing you can do, Jane, and I say that with all the empathy in the world. When Mary Collins went down in Tampa, her brain was already screaming for blood and oxygen. By trying to haul her into a sitting position, or worse, standing her up, you are forcing her heart to work against gravity to get blood to the brain. You are effectively starving the brain of the very thing it needs to recover. In Mary's case, she began to have what looked like a small seizure, but it was actually her brain reacting to the lack of perfusion. If her husband had tried to force water down her throat, she would have inhaled it into her lungs because her swallowing reflex was gone. What people need to realize is that the floor is actually the safest place for them at that moment, but only if they are positioned to breathe. We have this cultural habit of thinking that upright equals better, but in medicine, horizontal and protected is the goal. We have to teach ourselves to override that panic-driven urge to lift and instead focus on the mechanics of the airway. If Mary had been left on her back, her tongue could have blocked her throat, making that raspy breathing turn into no breathing at all.
So we are essentially fighting our own nature to save a life. It sounds like we need to treat the floor as a temporary hospital bed rather than a sign of failure. If we see a loved one like Mary on the floor and we've called for help, how do we bridge that gap between doing nothing and doing too much? How do we know if they are truly stable enough to be moved into this recovery position you talk about, especially when every second feels like a hammer blow to our chest? The
The bridge is observation, Jane. You have to become a calm observer in a storm of panic. You look at the chest. Is it rising and falling? You listen near the mouth. Is there a clear sound of air, or is it a gurgle? If Mary is breathing but not answering, that is your green light to move her into the recovery position. It is about creating a clear path for air. For Mary in Tampa, once she was finally turned onto her side by the paramedics, her breathing cleared up almost instantly because her airway was no longer fighting her own anatomy. We need to empower every husband, every daughter, and every neighbor to realize that their hands have the power to keep that airway open. You aren't just waiting for the ambulance. You are providing the most essential life support there is. You are the guardian of their breath until the professionals arrive, and that is a position of immense power, not helplessness.
There is a common image we all have in our heads when someone faints or collapses. We see them lying flat on their back, perhaps with someone fanning them or putting a cold cloth on their forehead. It's the way it has been done in movies and in our own homes for generations. We think that by laying them flat, we are giving their body a chance to rest and their lungs the most space to expand. But you are suggesting that this traditional flat on the back posture might actually be a silent trap. It's a bit shocking to hear that what we consider the most natural resting position could be the very thing that prevents a senior from waking up. Why is it that as we get older, this simple position becomes so much riskier than we ever imagined?
It is one of those medical myths that is incredibly hard to break because it seems so logical, but the anatomy tells a different story, Jane. When you are conscious, you have muscle tone that keeps your airway open, but the moment you lose consciousness or become severely lethargic, that tone vanishes. Think of the airway like a flexible straw. When you lie on your back, the weight of the tongue and the soft tissues of the throat causes that straw to kink or close entirely. For an older person whose tissues might be less resilient, this happens even faster. Beyond the tongue, there is the issue of the stomach. If someone collapses, their stomach sphincters relax and the contents can easily flow back up. If they are on their back, gravity sends that fluid straight into the lungs. It is a silent disaster. I have seen patients who survived a heart attack only to die from pneumonia a few days later because they inhaled stomach acid while lying on their back waiting for help. We call it aspiration, and it is a leading cause of preventable death in emergency situations involving the elderly.
That is a terrifying thought, that the very act of trying to let them rest could lead to something as grave as aspiration pneumonia. It makes me think about the fragility of the airway that we take for granted every single day. If lying flat is the danger, then the side-lying recovery position must be the shield. But I think a lot of people worry that if they move someone who has collapsed, they might disrupt something inside, or maybe they'll make a stroke or a heart issue worse by shifting the body. Is there a point where the risk of moving them is actually higher than the risk of them lying flat, or is the airway always the absolute priority?
In the world of emergency medicine, we have a saying, airway is king. Nothing else matters if oxygen isn't reaching the brain. If a person is not breathing, everything else, their heart, their brain, their kidneys, will begin to die within minutes. So unless you suspect a catastrophic spinal cord injury, such as they fell from a significant height or were in a high-speed crash, the priority is always the airway. For the vast majority of kitchen collapses or living room faints that our seniors experience, the side-lying recovery position is the safest choice. When you turn them onto their side, you are essentially opening that straw back up. Gravity now pulls the tongue away from the back of the throat, and it allows any fluids to drain out of the corner of the mouth onto the floor instead of into the lungs. It is such a simple mechanical fix, yet it saves more lives than many complex medications do in those first 7 minutes.
I want to make sure I really understand the nuances here. If I have turned someone onto their side because they were unconscious but breathing, and then suddenly their breathing starts to change, maybe it becomes very gasping or stops altogether, what then? Does the side rule still apply, or do we have to change our strategy again? It feels like we have to be constantly reevaluating the person on the floor, almost like we are their personal heart rate monitor.
That is exactly the right mindset, Jane. You are the monitor. The recovery position is for someone who is unconscious but breathing normally. If you are watching them and you notice that their breath becomes irregular, or they start making a snoring sound that isn't really breathing, what we call agonal gasps, or if they stop breathing entirely, you must act immediately. You have to roll them back onto their back and begin CPR, specifically chest compressions. You cannot do effective CPR on someone's side. So the recovery position is a holding pattern of safety. It protects them as long as they are breathing, but the moment that breathing stops, the situation has escalated from a protected airway problem to a stopped heart problem. This constant checking, looking at the chest, feeling for the breath on your cheek, is what keeps them in that safe zone until the paramedics can take over. You are never done just by moving them. You are their primary caregiver for every one of those 7 minutes.
In those moments of pure adrenaline and fear, when someone we love is unresponsive, our brains seem to go into overdrive. We want to do anything, absolutely anything, to bring them back. I've seen it in movies, and I've heard stories of people desperately trying to pour water down someone's throat to wake them up, or frantically searching for a pill to shove under their tongue. It's an act of love, but I suspect it's an act of love that can have devastating consequences. We feel like we have to fix the problem right there on the rug. But you've spent your career seeing the aftermath of these well-intentioned mistakes. What are the things we are doing in our panic that are actually making the job of the emergency room doctors so much harder?
The desperation to act is a powerful human emotion, but in medicine, sometimes the best action is knowing what not to do. I think of a man named Robert Jenkins, an 81-year-old from Columbus, Ohio. Robert was sitting in his favorite armchair when he started feeling a crushing pressure in his chest, radiating down his left arm. He was sweating profusely but still conscious. His family, seeing him in pain, panicked. They made him lie down flat on the floor immediately, thinking it would help him rest. Then they tried to give him a glass of water and some aspirin, but because Robert was so nauseated and lightheaded, he couldn't swallow properly. He started coughing and choking on the water while they were trying to help. This is the intervention trap. When you force fluids or medication into the mouth of someone who is not fully alert or who is struggling to breathe, you are inviting a secondary disaster. Robert didn't need water, he needed his heart to stop working so hard, and he needed a clear airway.
That story of Robert Jenkins is so relatable because the first thing we ask someone when they look ill is, do you want some water or can you take your medicine? It's our way of nurturing. But if someone is having chest pain like Robert and they are still awake and talking to us, does the recovery position even apply? It seems like there's a big difference between someone who is totally out and someone who is struggling but still with us. How do we distinguish the right move for someone like Robert versus someone who is completely fainted?
That is a critical distinction, Jane. Robert was what we call conscious but distressed. For a person having a potential heart attack like Robert in Columbus, the recovery position, lying on the side, is actually not the first choice. For him, we recommend the semi-reclined position. Think of it like sitting back in a recliner chair but on the floor with the back supported by a wall or some pillows. This position uses gravity to keep the blood from rushing too quickly to the heart, which reduces the heart's workload, and it makes it much easier for the lungs to expand. If the family had kept Robert in a comfortable semi-sitting position and kept him calm instead of trying to force him to lie flat and drink water, his oxygen levels would have stayed much more stable. The recovery position is specifically for the person who is unresponsive, the person who can't tell you they are choking. If they can talk to you, let them find the position that makes it easiest for them to breathe, which is usually sitting up slightly.
So the rule of thumb is if they can talk, let them sit. If they are silent and out, put them on their side. But what about the medications? We often hear about people keeping a nitro pill or an aspirin nearby just in case. Is there ever a time when the person at home should be the one to administer those, or is it always better to wait for the professionals? The fear is that by waiting, we are losing precious time that a pill could have saved.
It's a delicate balance. If a person is fully awake, can swallow without any trouble, and has been prescribed a specific medication like nitroglycerin for their known heart condition, then yes, helping them take it is appropriate. But, and this is a huge but, if they are confused, lethargic, or showing signs of a stroke, you should never put anything in their mouth. Many people think they are being helpful by giving a precautionary aspirin, but if that person is actually having a hemorrhagic stroke, a bleed in the brain, aspirin can make the bleeding much worse. In Robert's case, the family's attempt to give him water while he was nauseated nearly caused him to choke before the paramedics even arrived. My advice is this: your primary job is position and pulse. Get them in the right posture, semi-sitting for chest pain, side-lying for unconsciousness, and then monitor their breathing. Leave the pharmacology to the experts unless it's a pre-planned, doctor-approved routine. Doing less can often mean saving more of their life.
We've talked a lot about the why, Sanjay, but I want to get into the how. I want our listeners to close their eyes and imagine they are on the floor with their loved one. It's a scary place to be. The clock is ticking and the room feels too quiet. You mentioned that it only takes about 20 seconds to put someone in the recovery position, but in a panic, 20 seconds can feel like an hour, and our hands can become clumsy. I want you to walk us through it, step by step, as if you were right there in the room with us. How do we move a person who might be heavier than us or more fragile than us without causing injury? Is there a magic to the mechanics that makes it possible for anyone to do this?
There is no magic, Jane, only geometry. You don't need to be a bodybuilder to move someone into the recovery position. You just need to use their own limbs as levers. I remember a case involving a gentleman in his 80s and his wife who was quite small. This happened in a small apartment in rural Georgia. The husband had collapsed, and his wife, despite her age and small frame, saved his life because she had learned these steps. First, you kneel beside the person. Take the arm closest to you and lay it out at a right angle to their body, palm facing up like they are waving. Then take their other arm and fold it across their chest so the back of their hand is resting against the cheek closest to you. Hold that hand there. Now with your other hand, reach down and pull their far knee up until the foot is flat on the floor. Now you have a lever. By pulling on that bent knee toward you, the person will naturally roll onto their side. Their top hand stays under their cheek, which automatically tilts the head back and opens the airway.
It sounds so methodical when you describe it that way, almost like a dance. Arm out, hand to cheek, knee up, and roll. I can see how that would work, even if there is a significant weight difference. But I have to ask the question that I know is haunting every person listening who has osteoporosis or who has had a hip replacement. What if we break something? We are told our whole lives to be so careful with our seniors to avoid any sudden movements. Is the risk of a fracture or a dislocated shoulder worth the move? How do we balance the fragility of an 80-year-old body with the urgency of their breathing?
That is the most common fear I hear, and it is a valid one. But here is the clinical reality. A broken bone can be set, a bruised hip can heal, but a brain that has been without oxygen for 7 minutes cannot be brought back. If someone is unconscious and on their back, they are in a life-threatening state. The recovery position is designed to be a smooth rolling motion. It's not a violent shove. By using the knee and the shoulder together, you are distributing the weight evenly. Even for someone with fragile bones, a gentle roll onto the side is far less traumatic to the system than the cardiac arrest that follows a blocked airway. However, there is one exception. If the person has fallen from a height, like off a ladder, or if you witnessed a direct high-impact blow to their neck or back, you should be extremely cautious. In those cases, the Red Cross suggests keeping them as still as possible unless they start vomiting or their airway is clearly blocked. But for a typical medical collapse where they just slump to the floor, the airway is the priority, always.
A broken bone can be set, but a brain without oxygen cannot be brought back. That is a phrase that will stay with me. It clarifies the stakes so perfectly. So once we have them on their side and their head is tilted back on their hand and their leg is bent to keep them from rolling onto their stomach, what do we do then? Are we just sitting there? It feels like we should be doing more. Is there a way to monitor them in this position that gives the paramedics better information when they finally walk through the door?
Those minutes after you move them are when you become a detective. You stay right there at their head. You watch the rise and fall of their chest. You can even count the breaths. Are they taking at least 10 to 12 breaths a minute? You look at the color of their lips and fingernails. Are they staying pink or are they turning blue? And you check the mouth. Since they are on their side, any saliva or fluid will drain out. Just use a cloth to wipe it away so it doesn't pool. This is also the time to gather the essentials if you can. If you can reach their phone or their medication list without leaving them, do it. When the paramedics arrive, being able to say they went down at 2:05, I put them in the recovery position at 2:06, and they have been breathing about 15 times a minute since then is incredibly valuable. You are providing the medical history of those 7 minutes. That information is just as life-saving as the position itself.
We've been talking about the moment of the fall, the aftermath, so to speak. But I want to go back to the seconds or minutes before the floor meets the body. Many seniors are so stoic, they think a little dizziness is just part of getting old, or that their vision blurring is just because they haven't eaten enough. They don't want to raise an alarm for nothing. But in your experience, these nothing moments are often the body's final warning shots. If we can catch the crisis before the collapse, we might avoid the floor altogether. What are those subtle, often ignored signs that should tell a senior or their spouse that they need to sit down right now and call for help before the world goes dark?
Stoicism is a virtue in life, but it can be a death sentence in medicine, Jane. The body almost always tries to tell us something is wrong before it finally gives out. I think of a patient named Pat Miller, a 68-year-old woman living in Phoenix, Arizona. Pat was at a community center lunch when she felt a slight fuzziness in her head. She told her friend it was probably just the heat. Then she noticed that her left hand felt a bit heavy, like it had fallen asleep, and when she tried to take a sip of water, a little bit dribbled out of the corner of her mouth. She was embarrassed, so she just wiped it away and kept quiet. 10 minutes later, she tried to stand up and her entire left side collapsed. She had been having a TIA, a transient ischemic attack, which is a warning stroke. If she had spoken up at that first moment of fuzziness or that heavy hand, the outcome could have been so much different.
It is that embarrassment that gets us every time, isn't it? We don't want to make a scene at lunch or be the person who ruins the party. But with someone like Pat in Phoenix, those signs, the heavy hand, the dribble of water, those are the classic hallmarks of a stroke. When we talk about these early signs like dark spots in the eyes or ringing in the ears, how do we distinguish between a simple dizzy spell from standing up too fast and something that is a true medical emergency? Is there a red flag checklist that every senior should have memorized?
I tell my patients to use the sudden rule. If something happens suddenly and it feels different than your usual aches and pains, it's an emergency. For a stroke, we use the acronym FAST: face drooping, arm weakness, speech difficulty, and time to call 911. But for other collapses, watch for the 3 T's: tunnel vision, tinnitus, that ringing in the ears, and tingling in the extremities. If you feel any of those, your body is telling you that blood isn't reaching your brain properly. For someone like Pat, the moment she felt that fuzziness, she should have immediately sat down on the floor. Don't even try to find a chair, just get low. By getting low, you prevent the trauma of a fall. If you are a caregiver and you notice your loved one is suddenly confused, or their speech is just a little off, or they seem unusually sleepy, don't wait for them to fall. Get them into a safe position immediately.
So if we catch it early, if we see the face-arm speech issues and the person is still awake but clearly declining, do we put them in that recovery position right away, or do we wait until they actually lose consciousness? It feels so aggressive to roll someone onto their side while they are still looking at you, even if they can't speak clearly. What is the protocol for that in-between stage where the crisis is happening but they haven't hit the floor in a total blackout yet?
If they are still conscious and can follow instructions, the best thing to do is to keep them still and comfortable. For a suspected stroke like Pat's, have them lie down on their side with their head slightly elevated if they are feeling nauseated. This protects their airway in case they vomit. But the key is, do not let them walk. Do not let them go to the bathroom to splash water on their face. Do not give them anything to eat or drink. If they start to lose consciousness or become very drowsy, that is when you move them fully into the side-lying recovery position. The goal in that in-between stage is to minimize the brain's need for oxygen while maximizing the supply. Keep the room quiet, keep them calm, and tell them help is on the way. By acting during the warning signs phase, you are often preventing the full-blown collapse that leads to those terrifying 7 minutes. Pat eventually recovered, but she always says her biggest mistake wasn't the stroke itself, it was the 10 minutes she spent trying to pretend everything was fine.
We have all been there. In a moment of crisis, we reach for the things that usually bring us comfort. When we see someone struggling to breathe, our first thought is often to grab a pillow and prop their head up high. We think, if I can just get them more upright, they'll get more air. Or we see someone on the ground and our instinct is to grab them under the arms and try to haul them up, thinking that being vertical will bring them back to their senses. These are such deeply ingrained habits of care. But I'm gathering from what you've said that these comfort measures might actually be doing the opposite of what we intend. It's a hard pill to swallow, Sanjay, that our most loving gestures could be the very things that put our family members in more danger.
It is a counterintuitive truth, Jane, and it is one of the hardest things to teach even new medical students. Let's talk about the pillow. When a person is unconscious, their neck muscles are limp. If you shove a thick pillow under their head, you are actually pushing their chin down toward their chest. Go ahead and try it now. Tuck your chin to your chest and try to take a deep breath. It's much harder, right? Now imagine you are 85 years old and your airway is already compromised. By propping them up, you might be effectively sealing their airway shut. And the shaking or hauling them up. When someone faints, it's often because the brain isn't getting enough blood. Gravity is actually their friend when they are flat on the floor because it helps blood flow back to the head. When you exoc notch, pull them up by the armpits, you are forcing the blood back down to their feet. You are essentially extending the blackout and risking a secondary fall when they inevitably slip from your grip.
It sounds like we are inadvertently working against the body's own defense mechanisms. I think about the many times I've seen people try to give a person a sip of water or even a sweet candy because they think the person has low blood sugar. We want to nourish them back to life. But if the person is low-mo in that dazed or half-conscious state, how dangerous is that sip of water really? Is it just a little cough, or are we talking about a major medical complication?
We are talking about a major complication. In medicine, we call it the silent killer in first aid. If someone is not fully alert, their gag reflex is often gone. That sip of water doesn't go down the esophagus, it goes down the trachea and into the lungs. This can cause immediate choking, but even if they don't choke right then, that water is carrying bacteria from the mouth into the lungs, leading to a massive infection called aspiration pneumonia. For an elderly person, aspiration pneumonia can be much more difficult to treat than the original reason they fainted. The rule is absolute: nothing by mouth until they are sitting up, fully awake, and talking to you clearly. No water, no heart pills, no sugar. If you think they have low blood sugar, wait for the paramedics who can give glucose safely through an IV. Your job isn't to be a pharmacy, it's to be a protector of the airway.
So no pillows, no hauling them up, and definitely no snacks or drinks. It feels like we are being told to be hands-off, but it's actually about being hands-on with the right things. If we find ourselves in that situation and we've avoided all these common mistakes, what should we be doing with our hands? If we can't give them a pillow, how do we make them comfortable without risking their airway? Is there a safe way to provide comfort that doesn't violate these medical rules?
Comfort in a crisis isn't about pillows, it's about presence and temperature. If the floor is cold, you can put a blanket over them, but not under their head. You can hold their hand and talk to them in a calm, steady voice. Hearing is often the last sense to go, and your voice can keep them from panicking, which keeps their heart rate stable. If they are in the recovery position, the comfort is the fact that they can breathe easily. You can gently stroke their arm or tell them exactly what is happening. I've called 911, the ambulance is 4 minutes away, you are doing great, just keep breathing. That emotional anchor is far more powerful than a pillow. You are providing a safe environment for their body to do the hard work of recovery. By avoiding the helpful mistakes, you are giving the doctors a clean patient to work with, which increases the chances of a full recovery exponentially.
We talk about fire drills, and we talk about what to do in an earthquake, but we rarely talk about a collapse drill. It seems like such a somber thing to practice at home, rolling your spouse or your elderly parent onto their side on a random Sunday afternoon. But as you've said, when the adrenaline hits, our thinking brain shuts down and our habit brain takes over. If we haven't practiced it, we won't do it. I think about the many seniors who live alone or couples who only have each other. There is a deep fear of that moment of isolation. How can we turn this life-saving technique from a scary medical procedure into a simple, routine habit? And for those who are struggling with their own health, like chronic lung issues, how does this practice change?
Practice is the antidote to panic, Jane. I always tell my patients that the best time to learn to swim is when the water is calm, not when you're in the middle of a storm. I remember a patient named George Nguyen, who is 89 and lives in San Jose, California. George has severe COPD, chronic obstructive pulmonary disease, and he lives with his grandson. George knew that for him, breathing was always a struggle, and he was terrified of falling because he knew that if he were flat on his back, his lungs wouldn't have the strength to push against his own chest weight. George and his grandson decided to practice the recovery position once a month. It became a 30-second routine. Because they practiced, when George actually did have a respiratory crisis last winter, his grandson didn't have to think. His hands just moved. He got George onto his side, kept his airway open, and George stayed conscious and oxygenated until the paramedics arrived.
That story of George in San Jose is so inspiring because it shows that even with a chronic condition like COPD, you aren't helpless. But it makes me wonder, for someone like George, is the standard recovery position always the best? If someone is struggling with their breathing while still conscious, like in a COPD flare-up, is there a specific way they should be positioned that is different from the unconscious role? It seems like a person's specific health history should change how we react to their emergency.
You are absolutely right, Jane. Context is everything. For someone like George who is awake but struggling to breathe, what we call respiratory distress, the recovery position isn't the first move. For COPD or heart failure patients who are conscious, they often instinctively want to sit up and lean forward, resting their arms on a table or their knees. We call this the tripod position. It allows the accessory muscles in the neck and chest to help the lungs expand more fully. If you see someone like George struggling, do not force them to lie down. That is a common mistake. If they are awake, let them sit in that tripod position. However, the monthly practice we talk about is for the moment they stop being able to support themselves. If George had lost consciousness, his grandson knew that the recovery position was the only way to keep that COPD damaged airway from closing entirely. The goal of practice is to know both. Sit up if you're awake, roll to the side if you're not.
So it's a toolkit of positions. I love the idea of a Friday First Aid Minute, just 60 seconds to review the plan. But for the many seniors who live alone, like some of my neighbors, there is a worry, who will roll me? In those cases, is there anything a person can do for themselves if they feel that fuzziness coming on? Is there a way to fall safely or a position to aim for if you know you are about to go out and there is no one there to catch you?
That is the ultimate fear, and it is a reality for millions. If you are alone and you feel those warning signs, the tunnel vision, the lightheadedness, the first rule is get to the floor immediately. Don't try to make it to the phone across the room. You might hit your head on a table on the way down. Once you are on the floor, try to lie on your side. If you can get yourself onto your side before you lose consciousness, you have already done the most important thing for your survival. You have protected your airway. I also suggest that every senior living alone should have a medical alert system, but also a Toulon plan. Put a piece of paper on your refrigerator that says, call, breathe, position in big letters. It's for the neighbor or the delivery person who might find you. It tells them 1, call 911, 2, check if I'm breathing, 3, put me on my side. By practicing and by having a plan, you are taking the victim out of the situation and becoming an active participant in your own survival.
We have covered so much ground today, Sanjay, from the physics of the airway to the geometry of the recovery position. But I know that when the moment of crisis actually arrives, most people won't remember the clinical terms or the specific muscle levers. They need something they can scream to themselves in their head to stay focused. You have distilled all of this into 3 simple words: call, breathe, position. It sounds like a mantra for survival. I want to spend these last few minutes really cementing these 3 rules. If this is the only thing a caregiver or a senior remembers from our talk today, how should they visualize these 3 steps in those first golden seconds after a collapse?
You're right, Jane. Simplicity is the ultimate sophistication in an emergency. Let's break it down into the golden 3. First, GOI call. The moment you realize something is wrong, you call 911. Don't wait to see if they wake up in a minute. Don't call the neighbor first. Call the professionals. Every second you spend wondering if it's serious enough is a second that the ambulance isn't moving. Second, though, breathe. This is where you become the monitor. You put your ear to their mouth and watch their chest. Is the air moving? If the answer is no, or if it sounds like they are gasping for air like a fish out of water, you don't use the recovery position, you start CPR. But if they are breathing, even if they are unconscious, that leads us to the 3rd rule. Third, to the position. This is the recovery position we've been practicing. You roll them onto their side to keep that airway clear. Call, breathe, position. It is a 1-2-3 punch against tragedy.
Call, breathe, position. It is so clear. But I want to talk about the breathe part for a second more. I think a lot of people are terrified of the gasping sound you mentioned. We think, oh, they are trying to breathe, so I should just let them be. But you are saying that a gasp is not a breath. This seems like a life or death distinction that most of us would get wrong. If we hear that snoring, gasping sound, why is the recovery position the wrong move, and why must we roll them back for CPR?
This is a point that saves lives when understood. Those agonal gasps, they sound like a snort, a snore, or a groan, are actually just a reflex. They are not moving air into the lungs. If you see someone gasping and you put them in the recovery position, they will die because their heart has likely stopped. If the breathing isn't normal, regular, quiet, and effortless, you have to assume the worst and start chest compressions. The recovery position is only for the quiet sleeper, the person who is unconscious but whose chest is moving steadily and whose breath feels warm and consistent on your cheek. If that quiet breathing turns into gasping while they are on their side, you must roll them back and start compressions immediately. The tooth is only a safe harbor as long as the toe is stable. You have to be ready to pivot in an instant.
That is the ultimate vigilance. It's not a set it and forget it move. You are staying with them, hand on their shoulder, ear to their mouth until you see the flashing lights of the ambulance. Sanjay, I think about the millions of people who will hear this and feel a sense of relief. We aren't just waiting for help, we are the help. Before we conclude, is there one common mistake in these 3 steps that you see even the most well-meaning people make? Something that we can red flag right now so it never happens to our listeners?
The biggest mistake is the hesitation. People call, they check the breathing, but then they are too afraid to do the position step. They think, I'll just wait for the experts to move them. But in those 7 minutes, if that person is on their back and they vomit or their tongue slips, the experts will arrive to find a patient who has already suffered brain damage. Don't hesitate. If they are breathing and unconscious, roll them. Use that lever, get them on their side, and protect that airway. And the second mistake, forgetting to stay and monitor. Some people call 911 and then run to the front door to wait for the ambulance. Do not leave the patient. Stay at their head. Your observation of their breathing is the most important data point the paramedics will receive. You are the bridge between the home and the hospital. If you stay calm, follow the 3 rules, and don't leave their side, you have done everything humanly possible to ensure they come back home to you.
As we come to the end of our hour, Sanjay, I'm struck by a shift in my own perspective. We started this conversation talking about the fear of the fall and the terror of those 7 minutes. But listening to you, I realize that those 7 minutes don't have to be a time of darkness and dread. They can be a time of profound connection and life-saving action. It's about taking back the power from the what-ifs and replacing them with I know what to do. Many of our older listeners feel like their world is shrinking, that they are becoming patients rather than people. But you are giving them the tools to be heroes for one another. It's a message of hope that goes far beyond just a medical technique.
That is exactly the point, Jane. Medicine isn't just about what happens in my operating room or in the back of an ambulance. The most powerful medicine in the world is the knowledge that stays in the hands of the people. I want to leave everyone with 3 final thoughts to carry with them. First, please give yourself the gift of calm. When you practice these steps, call, breathe, position, you are training your nervous system to stay steady when the world starts to shake. That calmness is what keeps the oxygen flowing to your loved one's brain. Second, teach this to someone else. If you are a senior, teach your spouse. If you are a caregiver, teach your children. Make it a part of your family's language of care. And third, never forget how resilient the human body is, even at 80 or 90 years old. It wants to survive. It just needs a little help from gravity and a clear path for air. You are not a gunang, a burden, and you are not helpless. You are the first and most important link in the chain of survival.
The first and most important link. What a beautiful way to phrase it. It changes the whole narrative of aging from one of decline to one of preparedness and mutual protection. I want to thank you, Dr. Sanjay Gupta, for your time, your expertise, and most of all for your heart. You have a way of making the most complex medical realities feel like something we can all hold in our hands. You've given us more than just advice today. You've given us a plan. Thank you for being such a steady voice for all of us.
Thank you, Jane. It's been an honor. And to everyone listening, take a deep breath. Appreciate the air moving in and out of your lungs right now. It is a miracle, and now you know how to protect that miracle for the people you love. Stay safe, stay informed, and remember that you have the power to change the outcome of those 7 minutes. I look forward to our next conversation. Goodbye for now.
And thank you to all of our listeners for joining us on this episode of Healthy Kidneys After 60. We hope this conversation has given you a sense of peace and a clear path forward. If you found today's episode helpful, please subscribe to our channel so you don't miss our upcoming podcasts. We will be diving deeper into the signs of recovery and the ways we can keep our bodies strong and our minds sharp as we navigate these beautiful years together. Until next time, I'm Jane Pauley. Take care of yourselves and take care of each other.